My name is Michelle Booth, and I am I'm actually originally from North Kingstown, Rhode Island, and I live here in South Kingstown, Rhode Island, right up the road from URI. I graduated actually in December of 1994 with my bachelor's degree, and I returned for my doctorate, which I graduated in 2000. I did the non-traditional program. And why did I choose URI? Well, I'll be honest, I'm a Rhode Islander from birth. And if you think about what was available to me at the time, it would have been UConn or NCP that was, somewhat close by. And both of them did not have really good track records. They kind of had questionable things with their accreditation and whatnot. So I just chose URI because it was more of a sound program.
Okay. I'm actually a born and raised Rhode Islander myself, from Narragansett. And
Okay.
East Greenwich. So.
Oh, cool. That's great.
So I know when we kind of initially got in contact, the idea was kind of talk about managed care focused things, but kind of talking to Erica, it sounds like you're also pretty involved in specialty as well.
Yes. Yep. The specialty aspect of managed care, which includes drugs that are administered in the provider's office or at the hospital outpatient setting or at the home infusion site specifically, not so much drugs from a specialty pharmacy that might be oral drugs.
Okay. So do you think you could kind of just describe your role as a managed care pharmacist and like the type of things pharmacists are able to do in the managed care setting?
Yeah, sure. So I feel like managed care has somewhat evolved since I first started working in managed care. So I think that really the role of a managed care pharmacist is to assist a health plan in trying to manage their costs, bottom line, by providing the most cost-effective agent without compromising quality. And this can be done like in a variety of different ways. One of the easiest ways, of course, is to look at a drug class and see if there are, drugs, do they have equal efficacy? Do they have, for the most part, similar side effect profiles? Does anything set one apart where you would not want to cover it? But then, once you've done that due diligence, you look at the cost benefit and see, does one agent, everything else equal, does one agent show that it is less costly compared to the other agent? And is there a way for us to possibly preference that product? And that, obviously is pretty simple with the traditional pharmacy benefit, and actually what you would see with a PBM working with a health plan. But then, it's actually become quite common now to take that and apply it to where I am right now, which is more on the medical pharmacy side.
Okay. So kind of taking that stuff into consideration, like an average work day, like when you kind of, maybe you're remote these days, but typically when you'd like kind of arrive, it's more of an office setting, I would assume. It's like, what kind of things kind of do you do like on a day-to-day basis? Like what kind of people are you interacting with mostly? Just kind of like, I guess, what are your major responsibilities?
Sure. So right now, I am currently responsible for the clinical aspect of our relationship for a few different health plans that we work with. I work with a team, an account management team. We have an account executive who's really responsible for kind of being the day-to-day things that happen, like is the authorization file getting transferred properly? Is the web-based tool where the doctors go to request an auth, is that working properly? Is there anything that's come up that might be an issue with regard to anything that the health plan might identify. So that's their role. And then I also work directly with the health plan. So it's usually the pharmacy director that I would be working with from the health plan. Sometimes it's directly with their clinical pharmacist. It really depends on how their structure is. But then also I interact on my team. We also work very closely with IT folks and making sure that different, IT related items are in order. So if a drug is supposed to be on prior authorization, is that working properly? Is there a new drug we'd like to add to prior authorization? There's a whole slew of things that go into that. So they basically take a criteria and make a decision tree out of it from the computer software tool that we have. So I work with those folks, but then I also work with our data teams, which are like underwriting and analysts that are associated with the underwriting team, who provide us with utilization for the health plans across the board, as well as savings for the programs that we have implemented for the different health plans.
Okay,
So that's who I work with. In a nutshell, I think a lot of what I do, especially lately, has to do with, it's like email and questions, responding to questions that we have from the health plan. They may be asking about a specific authorization. We deal with Medicare, which is very kind of specific with regard to turnaround times and how you have your letters back to the provider and the member. So there's a lot of specific things, rules and whatnot that you have to follow for Medicare, Medicaid as well, and commercial, but it's not as tight as like a Medicare program. I also have quarterly meetings that I'm responsible for each of my health plans, where we kind of go through and do like a status check. We look at what the savings has been for the programs we've implemented. We kind of talk through that. And then, we are also looking at programs that we might want to be recommending for them. We've done a lot of talking about COVID and the drugs that are associated with either treatment or vaccination. We talk about the pipeline and drugs that may be impactful to them because they're going to be very expensive. Like we had a lot of, conversations, especially before gene therapies were approved, because, how do you treat these drugs? And they're really expensive. So how do you pay for them? So there's a lot of different things, and there's many different items that weigh heavy on a health plan's mind, especially when it comes to drugs, as you know, because that's a huge price tag when you look at a budget from like a health plan. So
right. So it sounds like there's a whole lot of kind of intercommunication between all different types of, I know you mentioned like clinical pharmacists, other types of managers, data analysts, and IT, among other people. Do you find that to be maybe challenging or difficult to kind of go between, I guess, communicating and setting things up with all different types of people of really different disciplines?
definitely. Part of it too is being able to speak to things that may be clinical in a way that an IT person or an analyst may be able to understand. There's that challenge, but also there's the challenge of having some difficult conversations with the health plan. Like, yes, you want to implement this program, but it's going to cost you this much. And, nobody really likes to talk about money. So that's usually my least favorite part of any conversation that I would have. It's definitely, it takes a lot of balance, and, you have to kind of, your personality needs to be as agreeable as possible with different types of folks, because you're definitely, even in the multiple health plans that I am working with, they all have very different personalities. They have different needs, different priorities. So yeah, it's a bit of a challenge, but I would say that the piece that is most helpful for me is I work with some really great team members, and knowing who to go to is really your first step. And if I don't know who to go to, I have some great folks that will point me in the right direction and help me out and be able to get the answers that we need.
Right. It definitely sounds like you have to be quite connected to do the things you do. So having people to kind of lean on seems like it'd be pretty important.
Definitely.
How did you kind of first become involved in managed care? Maybe like where'd you start? And like, did you kind of have any special experiences that predisposed you to kind of go further into managed care?
Well, as a student, I worked in hospital. I worked at actually South County Hospital for, starting in my third year. And I really enjoyed the hospital setting. I was actually very lucky to work with Dr. Charpentier, who at the time was working part-time with me. But she also had a role at a PBM, a local PBM, and got me a summer job working. And I was actually doing very simple things like filing and faxing and very basic entry level work, but it was in exposed to prior authorization, and this was fairly new. There weren't a lot of prior authorization programs out there at the time. I mean, we're talking about like, I don't want to even say, but more than 20 years ago. And I felt like, I learned something every day. I also had one of the roles that I was given was to do some research. So I actually would have to go to the library and pull articles and make copies of articles and doing like some digging to see, is our criteria appropriate? This doctor said that, they cited this study and said that this is why this drug is appropriate. So there were some really interesting aspects where I had to do some serious digging and reading and evaluating. Obviously not on my own, but presenting my recommendations to the other pharmacists, and we would kind of talk about these different, whatever it is, if it was a criteria or just a drug question, talk about that together. But then when I was, at the end of my rotations and getting ready to graduate, I actually was hired as a prior authorization pharmacist, and was actually very lucky to work there for 5 years. And I spent a lot of time, helping to create policies, doing some P&T or pharmacy and therapeutics drug reviews. So, for the class of drug or new drugs, making recommendations on policies and helping to put that together. So I really was immersed in managed care. And then the job after that I had was actually for a consulting company who it was also, for the most part, managed care, because we were working directly with health plans who may not have a pharmacy director of their own, and we were kind of acting as a pharmacy director or working with their pharmacy director to help with some of the projects that they had and whatnot. I also worked for Blue Cross of Rhode Island. I actually spent the longest time at Neighborhood Health Plan of Rhode Island, almost 10 years there, working as a clinical pharmacist, supporting their P&T, creating policies, coming up with strategies, digging into data. So a lot of what I do today, I did in other roles, just with the traditional drugs as opposed to more of the medical benefit drugs. So I have done some other things. I did actually work in hospital. I worked in a health center, worked at an anticoagulation clinic. So I've done those things, but right now I'm back to my roots. I'm back to the managed care aspect. And I do enjoy it. I feel like it's pretty rewarding. So.
Yeah, it's cool kind of the way you described, I guess, your career path was starting off with kind of the simple things with you just like faxing or doing prior authorizations, and then kind of working all the way up into designing kind of clinical, what's the word I'm looking for?
Program
Yeah,
strategy.
clinical programs and all that stuff.
Yeah.
It sounds really rewarding, definitely.
Yeah.
So that kind of, I guess, leads to my next question. In reading your bio, there was a sentence that I was hoping you could kind of expand on, and I'm trying to pull it up. Where are we? It's a good thing that these videos are edited.
Yeah, right.
So I have it up. So in the very last sentence, you have written that you support clinical program development, which you've talked about a little bit, specialty drug landscape and pipeline analysis. And I know, myself included, I can't say I know for sure exactly what specialty drug landscape and pipeline analysis are. So I was hoping you could maybe expand upon your kind of roles there and what exactly that means.
Sure. So I think it's a fancy way of saying that I keep track of a lot of the new drugs that come through. We do have a totally separate department that provides us with information on new drugs. And I don't have anything to do today with creating the policies or anything like that. But for my small team, which is like all of the pharmacists like myself working directly with health plans, I just work to create the some slides that we present every quarter to our health plans about drugs that have been approved, maybe anything that has changed. If a drug received, like Keytruda every week gets a new indication. If there's been new drug formulations, new biosimilars coming out, I kind of keep track of that. But also I have been involved in creating a document that helps us to keep track of the pipeline. So any drug that should be approved in the next couple of quarters, I kind of keep track of those, keep my eye on what's coming down the pike. We do, again, have a separate group of people that work on that more in depth than what I do, but this is more kind of tracking it for our team internally. And again, these are part of the slides that we present to our health plans. So if our health plan is particularly interested in gene therapies, they may want to pull out those drugs and say, hey, this is going to be a CAR T that's going to be approved coming up. It's for multiple myeloma. It's never been, it's an indication that hasn't been previously treated with gene therapy. So there's some things that each individual pharmacist may need to pull out for their particular health plan client. So that, I mean, in a nutshell, it's more like tracking and being aware of what's going on with new drug approvals and what's coming down the pike.
I see. That definitely seems like I guess a benefit almost, that you have to stay on top of everything that's changing, and you must have a pretty good idea, I guess, for like guideline changes. Anything new that's happening with medicine seems pretty important.
Yes, it's so hard to keep up with all that, and that's why I really rely on some of our other teams to make sure that I'm taking or finding the right information. It's like a second check for me to go and look at their documents and make sure that we're all capturing the same information. So
Right.
It's helpful.
So I guess, like, looking into the future, so to speak, it seems like I guess the pharmacist's role in managed care has come quite a long way in the past couple decades. Do you see the role of the pharmacist continuing to change? Are there like even kind of new opportunities that you're continuing to come across that you haven't before? Like, do you see the role of pharmacy in managed care? Where do you see it headed, I suppose?
So I definitely feel like it will continue because drugs aren't going to get cheaper, unfortunately. We need to start thinking of creative ways to pay for them. So that could be something that the pharmacist could be involved in making recommendations for. I feel like because a lot of the drugs that are approved are more expensive and on the specialty side, as opposed to like your traditional drugs that you would get through the retail pharmacy. I feel that there's probably a bigger role for a pharmacist in doing, say, maybe what I'm doing. I don't think that there are a lot of companies out there that actually provide this service. There are a few, and some of the big name PBMs have their own companies that do what we do. But I feel like, you know, if there's a health plan out there that's kind of doing this on their own, it's probably overwhelming because, you know, there were 56 drugs approved last year, and I would have to say that at least 40 of them were specialty. So, you know, they're all expensive. They have high price tags. The number of drugs that are considered high cost therapies or, you know, greater than like $300,000 a year is really increasing. So, you know, you want to be able to manage these medications and assure that the patients that are receiving them are appropriate. So I think that that's certainly a role for pharmacists in managed care moving forward.
Okay. Yeah, I tend to agree with all that stuff. I mean, as new drugs come out, they're seemingly more and more complex and expensive. So definitely room
I
for
know.
pharmacy intervention in a lot of those steps.
Yes, definitely.
Let's see. How would you say URI has prepared you for your, I guess you could say your current role, but just throughout all the steps of the career, how would you say URI has kind of got you to where you are?
So we didn't really have like a real class in managed care, and it was a very different. Managed care looks very different, you know, 20 something years ago. Where I feel like URI did a very good job of preparing me in maybe not necessarily like relating to what I do today, because the drugs are such a different mix, but being able to understand therapeutics and, you know, managing a patient and place in therapy for certain drugs and what's appropriate. I think that is definitely an area where I excelled because of my experience at URI. I feel like even now it's even better because of the way that things, you know, kind of seem to mesh better, where, you know, what you're doing in pharmacology is the same as what's happening in therapeutics. So I feel like URI probably does an even better job today than it did years ago. I would have to say that, you know, when I first went through, I did an undergrad class, and we all had to take biostatistics. Didn't really know how that would help me, but once I graduated and started reading studies and really trying to figure out why I needed to do, you know, understand all these different things, and then took it again at the doctorate level, I think that certainly prepared me too for, you know, better understanding studies. And I think it's very important for a pharmacist to be able to evaluate whether a study has been well done and what the results really mean. Not an expert, but I think that definitely helped prepare me.
Right. Yeah, and being a P4, I know one of our first classes in our professional years was drug information and analysis of literature, which is just kind of acquainting students with everything from all the like micromedics and lexicomps to PubMed.
Oh yeah,
Just being able to understand information, which sounds like something that would come in handy in a position
absolutely,
such as yours.
absolutely. I still every day I go into clinical pharm every single day, so
Yep.
it actually would have been. I mean, obviously we didn't have a class like that then, but I mean, I feel like that would be certainly extremely useful.
Mm-hmm. Yeah, I mean, even as a student, I'm constantly using, I don't know, 3 or 4 at least different kind of sites of drug information every day. So getting those
Absolutely,
skills down early, hopefully that'll help me out.
that's right.
I don't think I had any more kind of specific questions, but if there was anything else that you kind of wanted to mention, or if you have any messages for prospective URI pharmacy students who may be watching this video, um, I'll let you kind of take it away.
Sure. So one of the things I like to tell students is that you really shouldn't be afraid to take a chance. Obviously, working in managed care as my first job was not necessarily the traditional role of a pharmacist. A lot of what I've done thus far has been kind of taking the path not normally traveled by a pharmacist. I would recommend, if it's something that's interesting to you, you should absolutely try it. I also feel like it makes me very unique, knowing that I've had such different experiences in my life. And I think that would be the best advice I could give anybody, besides never say an answer unless you're positive. I believe the sentence is, I'll get back to you on that.
Yep.
That would be the second piece of advice. But really, don't be afraid to take a chance.